You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're glad you joined us. Before we begin, I'd like to thank our sponsors, Aultman Health System, Studio Arts and Glass, and Genier Appraisals and Liquidations. Today, Brad and I are broadcasting from our administrative offices, and our special guest is Michelle McCann, physical therapist with Aultman Therapy Services. Good morning, Michelle, and welcome to the show.
Good morning. Good morning, Brad. Good morning, Paul, and thank you for this opportunity.
All right. Well, welcome. If you have low back pain, you are not alone. Many people experience back pain in their lifetime. For example, at any given time, about 25% of the people in the United States report having low back pain within the last 3 months. In most cases, this type of back pain is mild and disappears on its own. But for some people, back pain can return or hang on, leading to a decrease in quality of life or even to a disability. Physical therapists help people with low back pain improve or restore mobility and reduce their pain. Physical therapists are movement experts. They improve quality of life through hands-on care, patient education, and prescribed movement. This morning, we're going to talk with Michelle about treatments for back pain and Aultman's Patient Navigator, who helps patients across all services available at Aultman to care for your back and spine. We'd like to remind our listeners today that our program is available on our podcast. Just look for Health Matters with the Medicine Center Pharmacy in your favorite podcast app, and please subscribe.
So, Michelle, welcome to the show.
Thank you.
Very happy to have you here. Please introduce yourself to our listeners.
Thank you. Again, my name is Michelle McCann. I'm a physical therapist. I have my doctorate degree in physical therapy. I've had the pleasure of working for Aultman for over 20 years now. I've worked for Aultman in a variety of settings for physical therapy. I started my career at Aultman West when Aultman West opened its doors. I've worked in the home health area of therapy, but my passion, heart, and expertise is in outpatient physical therapy. I'm located at Aultman Tusk.
Okay, so you don't leave the hospital? You stay there while Aultman Tusk?
Yes, Aultman Tusk.
Okay, all right. So what's your specialty?
My specialty is in chronic pain, back pain, the spine, and orthopedics.
And what other services are available at Aultman Tusk?
Aultman Tusk is well known for its vestibular and dizziness therapy program, expertise there. We also are known for our concussion rehabilitation. Physical therapy offers also pre- and post-surgical rehab, sports medicine, also services lymphedema, occupational therapy, speech therapy, and very soon we'll have our aquatic therapy program back.
Oh, gee. Okay. Oh, across the street.
Yes, we're neighbors. We are diagonally across the street. We're neighbors with the Canton Medicine Center location.
Yeah, that's right. There's a pool in there. I forgot about that.
Yes.
I watched them build it.
Oh.
Okay.
Mm-hmm.
Well, yes, and as a former patient of that facility for my ACL tear, I can compliment all of your team for the great work they do. And it is interesting how humbling going through physical therapy can be when you forget how easy and how much we take for granted what we do on a daily basis, whether it be walking, running, or anything. So it's nice to be able to kind of get that specialized training to get back on your lifestyle activities. What drew you, Michelle, to specialize in back pain?
A few things drew me to the back. When I started my career many years ago, it really was the complexity of the spine that intrigued me. But as I began to work with patients in the area, I really fell in love with the humanity of this profession. Our medical world is so very busy, but in the field of therapy, this is one area where we still have one-on-one care. I may see a patient 1, 2, or 3 times a week for a series of weeks. So I really get to have that relationship of wellness and walk alongside them. One more reason is the skilled care for back pain is in demand. Going to a doctor for back pain is second only to the common cold or flu symptoms for a patient seeing a primary care physician. So, high volume is very much in demand. And the last reason I would add to that, that draws me to the spine really is I feel physical therapists have a role in opioid reduction. As physical therapists, we're the musculoskeletal experts, and it really is musculoskeletal conditions such as back pain that are the most common diagnosis associated with opioid prescription.
So I'm kind of thinking if you ask 10 different people, you're going to get 10 different descriptions of what back pain is. So how about you give me your clinical description of back pain and how we can help patients decide what level they have?
That's a great question. Before we talk about back pain, let's talk about pain first, because pain is a normal human experience, and just learning more about pain, our human body is amazing. We have 400 individual nerves. If you stretch them end to end, they would measure 45 miles long. That is almost from Canton to the Brown Stadium. So just the complexity of the nervous system there. But all these nerves have a little bit of electricity traveling through them. That is normal. That shows that we're alive. And our nervous system is intended to function as a danger system. So when we have low back pain, that's our body saying, pay attention to this area. But there are many different diagnoses that can fall under the umbrella of low back pain.
So then tell me a little bit about back pain. I mean, I'm guessing it's not always because of an injury. It probably could be, is it part of the normal part of aging?
Well, that's a great question. I'd like to say having pain is normal, but living in pain is not. So 90% of low back pain can be resolved through conservative treatment like physical therapy. Those are really good odds. So our listeners, I'd love to have them remember from today that having pain is normal, living in pain is not. Come see our therapy team.
Very good. Well, and I think, maybe the question is, too, at what point should someone seek care? And I'm thinking, it's summer. You're probably working in the yard on the weekend maybe, and maybe you think you overdo it and you'll be okay in a couple days. At what point is that not okay?
If you're having pain that is affecting your function, your quality of life, give us a call. We have a program called our Back in Action program where you can call and speak to a live navigator. They will talk you through what are appropriate steps and how Aultman can best help you.
Okay. So what is the cost or burden of back pain for society?
The cost and burden of back pain can't just be measured in dollars. It includes lost work time, absenteeism, decreased quality of life. It's hard to put a number or a dollar on someone that has back pain that wants to simply stand in their kitchen long enough to prepare dinner, but their pain in their back is limiting them from standing for 20 minutes and they need to sit down every 3 to 4 minutes. The numbers on it really, though, are just astronomical in the United States in terms of how great of a burden it is when you involve, the workplace and lost work and lost quality of life.
So, someone's having back pain. What's the next move?
Give us a call. You can call our Back in Action program where we specialize in back and spine care. The phone number there is 330-363-BACK. So that's 330-363-2225. And when you call this number, you'll speak with our live navigator. They will help screen your concerns and then guide you through the next appropriate steps.
So is imaging including X-rays or an MRI necessary in any case?
Well, let's talk a little bit about what each which the typical imaging shows. For example, X-rays have been around for almost 100 years. They are simple and they are inexpensive, and they're very important to rule out serious problems and look at structure. Your CAT scan is your fancy X-ray that's like an X-ray, but more of a 3D image. And your MRI really looks at soft tissue. They use large magnets to look at the soft tissue. It looks at inflammation, swelling. Tissues that are inflamed have more or less fluid in them. So, for example, a disc bulge would show more, it'd be more evident because of the changes in fluid volume in that area. So imaging is appropriate, but from the physical therapy perspective, often with a skilled physical therapy evaluation, we can get to the root cause of the pain, sometimes with or without that imaging alongside us.
Okay, it's time for our first break, Michelle. You're listening to Health Matters with the Medicine Center Pharmacy.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Welcome back to Health Matters with the Medicine Center Pharmacy. Did you know we offer free prescription delivery? Call your Medicine Center Pharmacy to learn about our prescription delivery program.
Okay. Michelle, I wonder, we talked a little bit before the commercial break about imaging like X-rays and MRIs and CAT scans. Can you talk about what conditions that the imaging would show?
Sure. First of all, I'd like to say that imaging is appropriate to rule out red flags or serious concerns. Arthritic changes are often seen on imaging. Anyone that is over the age of 29 will likely have some degree of arthritic changes evident at the spine. An important fact, though, is that imaging can show what is not maybe the root cause of the pain. And the best example of that is considering imaging that reveals maybe a lower a disc bulge in your lower spine. For example, they did a research study where they took 100 people and did an MRI on these 100 people that had no pain, no back pain, no leg pain, and 40 of the 100 individuals in this study had herniated discs in their back. So there should be some peace or comfort in, to a certain extent, having a bulge in one of the discs in your lower back is a normal part of wear and tear on the spine. It can be a normal finding.
Interesting. You would think that if you had a bulge, you'd automatically have pain, but that's not what you're saying the study revealed.
Correct. So the study really helps to take away some of the fear in some of the findings, because the imaging findings showing something that may be alarming, and that's what part of what we'll do in therapy is walk alongside and work through some of the fears that go along with these common diagnoses.
Go ahead.
Just to go through the most basic common diagnoses related to the spine that we'll show on imaging or that we'll see in therapy are arthritis, sciatica, degenerative disc disease, stenosis, scoliosis, and spondylolisthesis. So those are a lot of the words. That's the most common.
So do we pick up stenosis with X-ray, or do we have to use MRI activity?
You could see that on both, but stenosis literally is a fancy word that just means narrowing. Our nerves need enough room and space and blood flow to work properly. So stenosis can be, it is a term to refer to narrowing around that nerve root, but in therapy we can work with what positions and what stretches and what's appropriate to open up some of that space around that narrowing.
How do we do that? I guess I always thought with stenosis there wasn't much you could do.
No, that's not true. I would love to see a client that had concerns about stenosis, because the balance of the muscles at the hip, lower back, and spine can really contribute to more tightness, and that tightness can add to the narrowing. So if you're doing the most appropriate stretches for your hip area, for your lower back, you can impact that space that you have. You can impact the mobility that you have.
Interesting.
So you mentioned some big words a minute ago. I wondered if you might talk with our listeners a little bit about the common diagnosis of the spine and maybe what that means as an impact on their daily living, if you could.
Well, I'd like to normalize some of these diagnoses. The diagnosis that I listed a lot of times are associated with a lot of fear, like your word degenerative disc disease. That sounds scary. That's a scary word for a doctor to say. So that scary or that fear contributes to pain. Our response to even the diagnosis itself can take pain and either turn the volume up or turn the volume down. All pain is real, but when we have the emotional response to it, it can make it worse. So if you were coming to therapy with a diagnosis of degenerative disc disease, we can work through the right education, and we have the time, the one-on-one time to walk through some of the education and normalize this pathology and get you started on the corrective exercises to help with the pain.
So how about, why don't we talk about the typical physical therapy experience? What would an evaluation look like for you to talk with the patient and try to determine what level of, therapy they may or may not need?
Okay, for your first visit for a physical therapy evaluation, I want to hear your story. I want to know, when did the pain start? How did this happen? What came on? What's the beginning of the story? So there's conversation at first. I want to hear about the onset. Then I'll go through an assessment where I do a physical assessment of the patient's spine. I want to look at their structure, their posture, and have them go through some repeated movements. I want to look at the quality and amount of movement in the spine. Our spines were meant to move. Then the next step is looking at their strength and their flexibility to the lower body. Our legs are our foundation for our lower back and spine. I go through some special tests that physical therapists are trained in to help understand the root cause of the pain. I'd also get to know the patient's baseline wellness. That matters in their recovery of the pain and pathology. And then finally, I would work with the patient. I want to know what their goals are. What would they like to achieve by coming to therapy? And we talk through the plan. And that plan may look like coming to therapy, 1, 2, or 3 times a week for a series of weeks to achieve these goals.
So you mentioned different forms of wellness in your message. Can you explain what you mean by that?
Sure. You referred to earlier physical therapists as movement experts, and we are movement experts. But for wellness, I like to think of therapists as wellness experts as well, because talking to a patient about their lifestyle choices is important regarding back pain. I'd like to know more about their wellness choices, for example, smoking, sitting, their weight loss, nutrition, their hydration, their sleep and stress. All of these can affect back pain. So is the patient ready to participate in physical therapy, and how can we help them be ready? Are they truly rehab ready to walk through this process of therapy?
All right, well, maybe we'll talk about rehab ready after our news break.
Thank you. Thank you.
Well, I guess it's time for our second break. It is the bottom of the hour for the time for the news. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Hi, you're listening again to Health Matters with the Medicine Center Pharmacy. I'm your host and pharmacist, Paul White. This morning, Brad and I are talking with Michelle McCann, physical therapist with Aultman Therapy Services. We have a lot more to cover this morning, so let's get back to the show.
All right. Before the break, you mentioned rehab ready. Can you talk about talk to our listeners about what rehab ready means?
Thank you. Being rehab ready just means, as an individual, are you ready to make habits that reflect these goals? So are you ready to make some wellness choices that show your desire to be healthier, to get your back better? An example of this would be kind of compared to maybe a prescription medication. If I have a patient and they're issued a home exercise program of a few specific exercises that they're supposed to complete twice a day, every day, they can think of it like their medication that they're supposed to take twice a day, every day. That compliance or that consistency has great value in reaching their goals, and they need to do their part when they're at home working on their rehabilitation.
So what does a typical physical therapy treatment or protocol look like?
A typical treatment is highly individualized. It really is based on that patient's evaluation. But what it might look like is coming into therapy and progressing exercises that were started at the right visit, going through them one-on-one with the therapist to make sure that you're doing them correctly, and then progressing those, advancing those to the kind of the next level to achieve maybe the strength or mobility or flexibility goals. We may have you do aerobic exercise to get your heart rate up and work on your overall wellness and conditioning there. We also do manual care in terms of massage or manipulation. We have modalities that we can use to calm down acute pain, such as electrical stim or ultrasound. So your therapy visit is typically 45 minutes or an hour, again, individualized based on what that patient needs, and it's all one-on-one care.
So, Michelle, what is PNE?
PNE is pain neuroscience education, and the field of physical therapy has grown over the last 20 years to not just focus on the anatomy or a tissue injury, but to focus bigger on including your brain, your emotions, your stress, your life experiences, the bigger picture of brain of the response to pain. So pain really is bigger than just the injury. So, for example, with back pain, it's much more than just perhaps the disc injury or the stenosis or the lower back. So PNE is teaching people about pain. It's based on the neurophysiology and neurobiology, but it's at a level that's easier to understand. It's using metaphors, examples to understand that language, because research shows that patients improve not just when they learn about anatomy in their therapy, but truly also learn about pain. It's education on how to release the healthy chemicals that are in our brain, the feel-good neurotransmitters in our brain called endorphins.
So what activities release endorphins then?
Endorphins are released with aerobic activity. A good rule of thumb is if you participate in an aerobic activity for 20 minutes and you're able to safely get your heart rate up 20 beats per minute above your resting value, so that would be a 20-minute brisk walk. That is releasing healthy endorphins in our brain. Another example of that could promote the endorphin release is the very popular HIIT exercises, that high-intensity interval training. That's popular in the exercise world right now, but that stimulates those healthy, feel-good neurotransmitters. An example of this also is with running. If you've ever heard of the term runner's high, if someone is going for a 6-mile run, there are neurotransmitters released in the brain that are equivalent to morphine. So therapy and pain neuroscience education can help a patient tap into those healthy endorphins that are already in our brain.
Okay, so a patient comes to you, for therapy, and let's say that this patient is on a high amount of pain relievers, clear into the narcotic class and all that. How do we? It's got to be the goal, I would think, of physical therapy to try and lower these meds. Would be my thinking. How do you do this? I mean, do you bring the physician in and discuss the meds, and all that kind of stuff?
That's a multidisciplinary approach, and through our Back in Action program, we have resources where I work directly with our pain management team. But every day the patient attends therapy, we are monitoring their pain goals. And for example, let's talk about a patient that maybe has had an orthopedic surgery, like a knee replacement surgery, which is a very, that's a major surgery. So that major surgery is normal to be on a narcotic pain medication right afterwards. But in therapy, we're walking alongside the patient, and each time they attend therapy, they are doing better with their mobility, their walking, the strength is coming back in their knee, their range of motion is improving. So I would expect to see a decrease in that narcotic need or use as they improve their function and truly decrease their pain. So that's something that we will, talk with the patient about, and we have that one-on-one time. And if I have concerns, then I can turn back to the physician and engage these concerns along with the educating the patient.
Over the years, as pharmacists, both Brad and I have seen an awful lot of pain meds dispensed and people on an awful lot of pain meds, narcotics, all that sort of stuff. What do you do with someone who comes to you who really is big time hooked? I mean, I can't believe that. I believe that you've got to see these people. I'll
tell you, I love to see these people because they need help, and they may not have been exposed to a safe place in therapy where they can learn to work out and engage some of the healthy endorphins that they can, release by going through a structured therapy program. I am not implying that physical therapy alone is what these individuals need, but therapy is very appropriate to be a part of this approach to help someone if their goal is to get off or lower the amount of their narcotic medication. And that I will really defer that to our pain management team, but I love to see these patients because it is very exciting to see someone improve when their identity had been attached to chronic pain and chronic opioid use. So those are really rewarding improvements.
In my lifetime, I've had a couple surgeries, and they were pretty rough. But I always told myself, I said, I've seen so many people that post-surgery have been prescribed this and that, and it's just very, very difficult for them to get off of it. So I always told myself that we're not going to do this very long if we have to, and we're going to go to a Tylenol product or, a Aleve or ibuprofen or something like that. So I have conquered that. I don't know how many people think that way, but I think Brad and I both think that way because of the individuals who we've seen over the years have great difficulty in, moving away from pain relievers. So, yeah,
this is a complex and very serious issue. This is serious across the United States and even in our area with the opioid epidemic. And in physical therapy, we want to do our part and do what we can. And we have a trusting relationship with a patient, and we see them for longer periods of time. So we have the opportunity to have conversations to really encourage wellness in these areas and to look for red flags. So we just will keep striving to make gains at the individual level when it comes to opioids.
I just wanted to comment on something that you said, which I have a feeling that there might at least be some of the population that might be listening today that thinks physical therapy equates to being painful. But I have a feeling you have a comment on that statement. So tell me what you're thinking.
Well, we were meant to move, and physical therapy is not a passive care. So you are, when you attend therapy, working with a therapist, there's no pain, no gain. I don't like that, but perhaps engaging what we call sore but safe, knowing that you may feel something, this may feel different because we may be educating or challenging you to do an exercise that you haven't done before, but settling into the concept of sore but safe, we're not going to ask you to do something in therapy that's not safe, and we are working towards making changes if you need to make changes in your mobility, your strength, your flexibility. So that comes with doing specific exercises. So I appreciate your question. Therapy, please don't equate that with having pain. We want to have you do all the right things.
Very interesting. I think it's time for the break, right, Brad?
Yeah, let's take our last one, and then we can get that out of the way.
Sure. Final break is here. You're listening to Health Matters with the Medicine Center Pharmacy.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Welcome back to Health Matters with the Medicine Center Pharmacy. Today we're talking with Michelle McCann. Is that correct? Am I pronouncing your name at the end of
Yes, that's
near
correct.
the end of the show? Okay.
Yes, correct.
Okay. I was kind of wondering what sorts of therapy that you do, in fact, use over there in your facilities. Do we use traction still? Do we use sound, ultrasound? What all do we use in these days?
Sure, you're speaking about some of our modalities, and we can use traction when it's appropriate. We can use ultrasound, which is that high-frequency sound wave to produce more of a healing, deeper stimuli to the tissues. Electrical stim, for example, that's like a TENS unit, is still used for pain. So the modalities have their place in calming acute pain, but the field of therapy is trending towards using modalities as needed, but really empowering a patient to make the changes in their body with the right exercise, with the right aerobics. So we are doing yoga-based interventions and meditation and even journaling for pain. It's more than just the modalities in terms of the whole care.
Interesting. So, what about in physical therapy, chiropractic techniques? Have any of those kind of drifted into physical therapy, normal physical therapy? What did they say? Normal. I'm sorry. Go ahead.
Physical therapists are trained in some manipulations. When you think of a typical chiropractic care, I think you may be referring to a high velocity thrust style manipulation to the spine, and that's something that we are trained in therapy, and we can use when that's appropriate. The philosophy may be different in terms of I want to empower the patient so that they so that ultimately they're doing so well that they don't need to come see me. So if I need to help with an adjustment in terms of alignment, we will. So maybe the difference that you're referring to is the volume of the manual approaches in the two different settings. Did I answer your question?
Yeah, you did. Okay. So okay, I come to you for therapy, physical therapy. Okay.
Please do.
Okay. I probably could use a lot of it, but anyway, does a team evaluate my injury, my condition, and decide how to handle the therapy, or how do we do this?
Well, let's start at the beginning. If someone has back pain and calls our back in action line, because that would be the beginning of the story, or they can be referred directly by a physician, their primary care orthopedic. But if they call that 330-363-BACK line and speak with a navigator, then and if the decision is that they're arriving at physical therapy, one physical therapist, for example, myself, would do that initial visit and establish that plan one-on-one with the patient. And then we do have small teams that carry out the routine visits. So a small group. When you come to therapy, you may see, one or two different therapists within that team.
Okay. So it's not really like, okay, here's Paul White, and he's got this back pain, and okay, we're going to have all kinds of X-rays and maybe even the MRI, which I know is extremely difficult to log through most commercial or most insurances and get it approved. So not that way, huh?
Well, if a patient attends therapy and they feel that they need an MRI, you're talking about insurance. Sometimes insurance wants to see that they've completed several visits of therapy. I go into that patient encounter with the mindset of perhaps I can get you doing so much better in this short time that you may or may not need that imaging. So the insurance may be looking for therapy to make improvements before they're ordering or before they're covering that more expensive testing.
MRIs are not particularly fun. I've had 2 or 3 of them. So.
They sure are loud.
Yes, a whole lot of banging around, particularly when you get a whole body one. So anyway.
They're just showing a good picture there. But keep in mind when you're talking about different imaging that it's like a Polaroid. It's just one picture. In our society, we have thousands of pictures on our phones and selfies, and it's just one picture. So it is an important picture. It's information, but it doesn't tell the whole story. A movement-based assessment is so valuable to learn how pain changes with change of position and more to that story.
Interesting.
Before we run out of time, Michelle, I wondered if you could make a comment about patients that like to use Dr. Google.
Oh, that's a good question. You have to be careful with that, especially for the spine, because if you look up, what exercises on Google should I do for my sciatica, you may get very different and possibly concerning exercises, because sciatica really is a fancy word that just means leg pain coming from a nerve, going from the back to the leg. So is that sciatica? What is the root cause? Is it coming from a degenerative disc or a disc bulge? Is it coming from a stenosis and a loss of height? Because we would treat those very differently in physical therapy. So be careful what you're looking at so that you don't either injure or prolong an injury. So come to therapy. I'd like to learn about what you've tried so far. Sometimes on that first visit in therapy, someone will tell me, well, I've tried this and this is not helping. Well, so what we learn from that is that let's do the right exercises. So be careful with Googling.
All right. Well, you have an amazing team over there, and I appreciate you and what you've done. And I wondered if maybe for our listeners, you could give your back phone number again and how listeners can contact you all. And also if you can touch on, you mentioned earlier in the program, but I don't think you necessarily need a referral. So if you could cover that, it'd be nice to sum that up before we go.
Okay, yeah, that's great. Typically in therapy, you would have a referral so that as a therapist, we have a physician to refer back to. But now we have direct access where if you need therapy, you can call the 330-363-BACK, which is 330-363-2225. That's our Back in Action phone line, and that line will directly connect you with the patient navigator for Aultman's back and spine care. Services offered there are, again, our therapy. Aultman has neurosurgery, Aultman has orthopedics, imaging, pain management, but coming to us for that first visit, you can come see a therapist directly now.
Excellent.
How are we doing for time?
I think we're done.
Okay, doke.
I think we're out of it.
Okay, thank you to our guest, Michelle McCann. We enjoyed having you with us today.
Thank you again.
Physical therapist with Aultman Therapy Services. We'd like to remind our listeners, if you suspect you have a medical issue, please contact your healthcare provider. Thanks to our sponsors, Aultman Health System, Studio Arts and Glass, and Genuine Appraisals and Liquidations. As always, we thank our listeners for joining us on Health Matters. Thank you again, Michelle.